time, it would just bring the whole delegate thing to me. Anyway. So you can start with the introduction. By the time I will share the screen.
Sure.
Right. So we'll go live. It's 4 o'clock. So yeah.
We are live.
Over to you. Yeah.
Thank you. And good afternoon, everybody. I'm Sandeep Bansal. I'm professor and head of cardiology at Delhi's Safdarjung Hospital. And we're all learning this new way of, talking with each other and this new way of teaching, that is through the webinars. And I welcome you all to this afternoon's meeting. And this says a measurement of blood pressure. Does one size fit all, or is one way the best way of measuring the blood pressure? And we've got a very eminent faculty over here. We've got Dr. Tiny Nair, a renowned cardiologist from Kerala. He doesn't need any introduction at all. We all know him as a very prolific speaker. We also have Dr. Uday Jadhav from Mumbai, another very leading cardiologist across the country, and in fact internationally. He's done a lot of work in the field of hypertension, and we need to understand that blood pressure is a measurement. Blood pressure or hypertension is seemingly a very simple problem, but as they say, it's the mother of all problems. In fact, in the global burden of disease series, two of these have been published, one in 2012 and another in 2017 perhaps. In both of them, the blood pressure is an absolute outlier. It's a multiplier of all the risks. Its risk exceeds all other risks or problems that we know of. So we are talking of a problem that has that is of phenomenal proportions. And when we are talking of that, then suddenly we realize that it is not so simple, and there are a lot of points, there are a lot of nuances that we need to know about. And one such aspect, which seemingly is simple, but in fact is very complex, is actually how do we measure the blood pressure? Traditionally, as we all know, we have been measuring the blood pressure in office. Although the measurement of blood pressure in the office itself has been undergoing a lot of changes, there are a lot of other ways in which we need to or have to or are advising our patients to get the blood pressure measured, which is also known as the out-of-office blood pressure measurement. So to set the ball rolling, we'll have first Dr. Uday Jadhav. He's going to tell us about the blood pressure measurement in the office and how do we go about doing that. Over to you, Uday, and welcome.
Thank you, Sandeep and Tiny. It's been a pleasure. And without spending any more time, let me start with the presentation. I'm going to talk on the blood pressure measurements. So let me briefly discuss. Dr. Sandeep has already briefed you the importance and how we are going to go about the blood pressure lowering. And let me sort of take very simple basics before, in a very short time frame before Dr. Tiny will take over and explain us further. So what we intend to do is look at what are the basics in terms of what we are going to do with blood pressure, what is the importance of office versus the automated blood pressure, how do we put in a clinical relevance? And we know we are dealing with a very high global burden. Is going to go up to 1.5 billion. So these are all known aspects. What is more important is, are we missing on many individuals who have a high blood pressure? Possibly also labeling some patients who do not deserve blood pressure lowering therapy as aggressively as we might want to. So let me look at some of these errors. Now, I do not know whether you can see these slides very clearly, but there are small, very important things there. That when we check the blood pressure, whether it is the mercury sphygmomanometer, which is getting out of vogue, or whether we do it with the automated one, it's important to use the correct cuff size. Look at how small things make a difference. If you use a smaller cuff size, there can be a difference of 2 to 10 millimeters of mercury. If we put the cuff over the clothing, over the forearm clothing, over the shirt, it goes up from anywhere from 5 to 50 millimeters. So I try to look at it in clinical practice, what happens. And I found that the difference is anywhere between 10 and 30 millimeters of mercury. So it's quite high if you just tie in your very busy days the cuff over a clothed arm. The arm should be at heart level, otherwise it goes up by another 10 millimeters. There are two important things. I mean, one is the way the legs are placed. They should not be crossed, and the feet and the back should be rested. Otherwise, an unsupported back and a feet can add to another 5 to 7 millimeters of mercury spike. So these are some of the important aspects of how we take blood pressure, and we'll talk about it a little more in detail. Now we look at the definition of hypertension, and when we look at the definition of hypertension, these are the various guidelines which we have been told. Amongst the guidelines are the ACC, ESC, and the recent ones, the NICE guidelines. There's the Canadian guideline. So let me make a quick comment on this. How do you balance a office blood pressure, that let us call it as automated office blood pressure, a home blood pressure, and a ambulatory blood pressure? So if the blood pressure in the office, putting all the guidelines together, whether you call it 130 by 80 or 135 by 85, if the blood pressure in office is exceeding 135 by 85 millimeters of mercury, there is a suspicion that the patient could have hypertension. So then we should ask the patient to go back and check it as a home blood pressure. If the home blood pressure is less than 130 by 80 millimeters of mercury, probably he doesn't have a hypertension. Recheck him in your office. If the office blood pressure is always on the higher side than the home blood pressure, there is a possibility that the patient could have a white coat hypertension. Then you have this approach that you get an ambulatory blood pressure as a referee to help you out. And if the ambulatory blood pressure monitoring gives you a reading on an average less than 130 by 80, then you already know that this was a patient of white coat hypertension. How you will approach it is a different topic, but then that's not the labeled classical hypertension that we see in clinical practice. If the blood pressure is more than 135 by 85 in your office, and at home the blood pressure is also more than 130 by 80, then it is definitely a hypertension. And by the current ESC guidelines, home blood pressure monitoring is what will define a hypertension. So that's making it short. So here is the route which has been shown, and it's very proper. Patient should sit comfortably, quietly for 5 minutes before you start doing the blood pressure measurements. Preferably, there should be 3 readings. And these 3 readings should be kept 1 to 2 minutes apart. It's only when there is atrial fibrillation that you have these issues about what would be the real systolic blood pressure. And you may take 3 readings and average it out and probably use a sphygmomanometer and take a better call on that. The cuff should be a standard bladder cuff. As I said, put it on an unclothed arm, back and arm supported. Use the auscultatory methods, either way. What is required besides all this is just be sure that the patient is reasonably reassured and settled before you start the blood pressure. And if it is a home blood pressure monitoring or even a clinic home blood pressure monitoring, it should not be on a full bladder. So the blood pressure is always recommended at home after the patient goes to the restroom and comes back, or in your clinic, please ask him to avoid urine if he's on a full bladder. The adult generally cuff size in general is 23 to 33 centimeters, and that's the proper one. And we should always try and do that. Here are the same precautions said: no coffee, no immediate exercise, no smoking, empty bladder, and use all these aspects in mind when blood pressure is being recorded. Try and get it done in both arms. Palpatory method for the radial artery can be utilized as you require it. And auscultation is the classical standard by which we have learned even as medical students how to do it. Just ask the patient to remain still, sit correctly, take multiple readings, record all readings accurately, right? No talking during measurement, neither by the doctor nor by the patient. This is very common. Patient chats and you also ask him some other question. That doesn't happen. As a clinician, concentrate that you're measuring the blood pressure. So sometimes it happens, you know, as professionals, you are thinking of something else. And by the time you have started taking the BP, you forget what the systolic blood pressure was when it all started. So just be focused that this is something that has to be given a good importance. And the rest of the measures which have been shown here in these slides are absolutely what are recommended as standard procedure. And they are all very simple. It's not that you have to list them and it takes a long time. It just happens very quickly once you know that these are the standard protocols of blood pressure measurement. So the devices are the auscultatory, the automated electronic devices, the ambulatory blood pressure monitoring, and a out of the office home blood pressure monitoring, right? So here is the classical auscultatory and the oscillometric one. What is important also to understand when you auscultate this, that there should be a gentle lowering. You know, when we deflate the cuff, it should be done little gently. If you quickly do it, then there is a possibility that you get an erroneous reading. Also, when you inflate it, it should be a very smooth. So smooth transition down to up, smooth transition up to down. And that can save you as many as 5 millimeters of mercury mistakes when you do it. 4 entities: normal, white coat, masked, and sustained. Neither masked nor white coat hypertension is any more benign. We know these are all phenomena. Masked hypertension can be as bad as to cause a target organ damage. So you can have a patient with left ventricular hypertrophy, normal blood pressure in the clinic, high blood pressure outside the clinic. These are not benign entities. We need to be very, very careful. So masked, white hypertension, sustained hypertension, the change from pre-hypertension, so-called in the earlier days, to hypertension, all this is a matter of concern and should be approached in a proper therapeutic fashion. Automatic blood pressure and office blood pressure, and I'm going to make a couple of comments on this. So is it a preferred alternative? It is. I will show you a few slides, but let me make a comment. So there was a meta-analysis by Professor Marcos, which was published in Hypertension exactly a year back. That's the largest meta-analysis which has been published on the comparison of automated office blood pressure and the blood pressure at home, which the patient records. And this is what came up: that the home blood pressure monitoring is absolutely accurate. It's as good as the automated office blood pressure monitoring. And the automated home blood pressure monitoring equal to HBPM are able to predict even the CV events and the outcomes, and even the matter of stroke. So this is really, really very good. That was one piece of information added. The second important thing that came through, how many readings you need at home. So patients, sometimes it's cumbersome. Go on doing it all the time and they'll text you all the time. And it's a bit of a concern for busy clinicians. But is there a parameter of blood pressure which is very reliable? So it is the morning blood pressure, which really, really helps. The morning blood pressure is very accurate in terms of prediction of what the event rate would be. So even if you don't have two readings, the morning one is good enough and should be used in clinical practice. So those were the two important clinical messages that came up from this meta-analysis. And there is one more paper which was published in JAMA Internal Medicine, which tells you the same thing, that the office systolic blood pressure could be 15 millimeters higher than what you get as an automated office blood pressure. Automated blood pressure was lower than the routine office blood pressure, and there was no difference in automated and the other reading. So what are we trying to put up as all this? That the automated office blood pressure is very, very good. You can utilize that as a perfect tool in terms of what you are going to do in clinical practice. The home blood pressure also in this context is something which should be almost like a step one now. And I would say ambulatory blood pressure monitoring, though I'm very fond of it and we have been in clinical research for a very long time, I'm saying that for a country like this, a validated home blood pressure monitoring is really good. That brings us to the last point. Are these very accurate? So there has been a study that looked at the devices difference, reading difference, and what readings that the devices will return back in terms of accuracy. So the change in the accuracy can be to the tune of 5 millimeters of mercury in about 70% of the patients, and that's acceptable. Only in 7% it exceeds 10 millimeters. So if you have a validated device, there is no reason to suspect and believe that these devices are no good, because that's a common fallacy that sometimes clinicians have in mind, that no, they are not good. They are, provided they are validated. And that's how we should approach blood pressure in clinical practice. So Dr. Sandeep and Tiny Nair, thank you very much. Let Tiny take over.
Yeah, thank you, Uday. That was a great talk. And we'll have the questions and discussion at the end. So now I'll invite Dr. Tiny Nair to tell us about out-of-office blood pressure monitoring. Dr. Tiny, please.
Dr. Uday, could you just stop sharing your screen? Yeah, that's right. Good afternoon, gentlemen. Good afternoon, Sandeep and Dr. Uday. In fact, I think, like Dr. Sandeep said, that there's an entire change of the way we look at how we present, how we transact our training, our teaching, our sharing of concepts have entirely changed in the last about a month or so. And we are learning quickly how to go to digital. We are learning to transact through telemedicine, which I think is an important benefit of this whole pandemic and the whole crisis. Now, I would be talking in the next about 15 minutes or so on out-of-office blood pressure and what is new in out-of-office blood pressure. Now, as Dr. Uday said the background, today we know that out-of-office is important to blood pressure for very many purposes. Now, first thing, of course, out of office is something that is always enjoyable, right? People go for a holiday out of office, you get emails back telling that I am out of office. But especially when we are talking about out of office of a doctor's office, the patient really, really, really feels bad. We are all aware that how a patient feels when the blood pressure is taken. Some people are extremely sensitive, so that the moment the blood pressure cuff is put in, their blood pressure shoots up. So to prevent that, we today have two basic ways to estimate blood pressure at home, right, out of office. One is an ambulatory blood pressure. We all know ambulatory blood pressure is the instrument that we put around the arm. The instruments have become smaller and smaller and smaller and more easy to carry, more portable. They are hooked on to the belt or the waist like a very small cell phone. And they go on intermittently inflating and record the blood pressure. Now, like Dr. Uday said, they're very good. In fact, we get in fantastic data into their blood pressure once they reach home during their sleep. But the problem or the challenge is that as the blood pressure cuff inflates, it disturbs the sleep. Almost every patient whom we have seen, they would come back and say that, doctor, when the cuff inflates, I wake up. It is a disturbance. So it actually is not the sleeping BP, but intermittent nocturnal blood pressure. But given away that, this extremely beautiful tool, and we will show you how things we have learned, and there's a lot of new stuff that we have been learning. The other new thing is the home blood pressure. Home blood pressure started as a simple automated blood pressure that you put in your cuff and record. But as we know, the moment the patient himself puts the cuff and blood pressure inflates, the switches on the instrument, he is likely to become anxious and the blood pressure is going to go up. So this is one of those home BP apparatus that we recommend, and we used it for, I will show you the data for our study called the Indian Heart Study. These BP instruments you can program in any way. Now, the way we programmed was, this is used for 1 week, thrice a day. And during the sessions, the first blood pressure automatically is taken out of the average, second to our average. That is the standard algorithm. But the point is, the blood pressure instrument doesn't just go up and come down. After the first measurement, you get a 20-second gap. When the instrument remains silent, it once there's a negative clock, then inflates and deflates again. And then the third reading. So you get 3 readings and at the end an average. Even you can program it so that this will not show the data to the patient, so that once the patient comes in, you get the entire data. The first day's data is always trashed, and the second day onwards data is taken. You can program again it any way you want it to be. Now, when do we use in home BP, right? You can use it in every patient you want, but if you take the number of patients, 12 to 15% of your patients are hypertensive. So in this huge country, we can't recommend it for everybody, right? So whom should we recommend home blood pressure? The first thing is discordance. Discordance between what? Discordance between your blood pressure recorded in the office, right? You are recording a blood pressure in the office versus the target organ damage that you estimate. Okay, so you have a patient whom your blood pressure is very high, right? But you see, he is fine. There is no left ventricular hypertrophy. He never had a CVA or a TIA. He has no nephropathy. He has no retinopathy, right? So there's a discordance. This man may have a white coat hypertension. Obviously, we recommend a ambulatory or an out-of-office BP for him. The other end of the spectrum is where his blood pressure may be normal or slightly elevated, maybe 145 or 95, but the ECG shows a huge left ventricular hypertrophy, or he shows plus of urine albumin, or you see that the ophthalmic doctor calls up and says his retina is significantly hypertensive. So there's a discordance between the blood pressure that you recorded in your OPD, in your office, versus the target organ damage. So any discordance between these two, we go for out-of-office blood pressure. Now again, understand that the concept of white coat hypertension is different in India, right? We all talk about sprint trial where patients were put into a quiet room, a conditioned room, carpeted room, soft music, and an unobserved blood pressure was taken. But consider in India, that is a picture of patients waiting with a token outside our OPD. I'm sure that in Delhi and in Mumbai it is same, right? Where people are waiting with a token to see you. They hardly have a seat to sit there. And do you think their blood pressures are normal? They're anxious, they're angry, they're hungry, they're waiting for such a long time, right? And not just that, just before that, imagine that they stood in that long queue to get a token for you. They might have come early morning, far away places. So office or doctor's office is not the right way in India to record blood pressure. So in India, when we talk about white coat hypertension, it's not just that the patient becomes anxious, but the whole system is such that an Indian hospital, an Indian office, doctor's office, is not meant to clearly give us one single examination result, whether the patient has high blood pressure or not. And that is important to understand. So if we talk about white coat hypertension, what is white coat hypertension? We know that if you see those who are unaware about reading an ambulatory blood pressure record, the top gray strip is the systolic blood pressure, the bottom gray strip is the diastolic blood pressure, the top black line is the systolic blood pressure, the bottom dark line is the diastolic blood pressure. So see, in this record, as the patient is in the hospital, the blood pressure is pretty high, right? The moment he has come home, his blood pressure is all within the range. He comes back to the hospital, again the blood pressure has gone up. The typical record of a white coat hypertension. And today we know that the white coat hypertension is not benign, right? They stand somewhere between an absolutely normal person and an hypertensive with multiple target organ damage, somewhere where he's likely to become more hypertensive, but perhaps lesser problematic than the mass hypertension. Now, what is interesting is we now found, today we have an enormous experience of ambulatory blood pressure. We have found that there are some special kinds of, unusual kinds of ambulatory BP, white coat hypertension in India. One pattern is that where the top line, if you see, is the systolic blood pressure. The bottom line is diastolic blood pressure. If you see very carefully, there's another dotted line, right? And that is the heart rate. Most ambulatory blood pressure will give you the heart rate also. So there's a group of patients where you see as the patient has gone home, not that just the systolic blood pressure has come down, the white coat sympathetic effect, his heart rate has also come down. So his heart rate and systolic blood pressure are in sync. These are a group of patients who just have the one like graph you saw, hospital, their blood pressure is high, they come back to the hospital, again high, in between normal. Intermittently, if they're exposed to some kind of stress, maybe office stress or home stress, blood pressure tends to shoot up. But we also find another group of persons, okay, where we see that the blood pressure is high, okay, when he has reached home, it has come down, but the heart rate is pretty flat. They're not on medications, right? But somehow there's a discordance between the systolic blood pressure and the heart rate. Why, we don't know. But these are the group of patients where you tend to find more of an early morning rise of blood pressure. These are the patients who tend to have a higher amount of target organ damage. Why, the answer is not known. In fact, we had put that in our article where we said that common but underrated. These kind of white coat hypertension are common but underrated. Are we neglecting these hypertensive subsets in India? So they are common. Keep an eye on it. If your patient of white coat hypertension also has a lack of drop of heart rate, okay, as the systolic blood pressure comes down, if you see that same person has got an early morning rise of blood pressure in the early morning, the moment he wakes up, these are subsets which are likely to have more of target organ damage and problem. The second set is even more difficult to find out unless you keep your eyes open, and that is mass hypertension. So this is a diagram of mass hypertension. You look at that curve. The green is systolic. Daytime, you can see that the blood pressure is slightly high, but not very high, slightly elevated. But at night, you see it is significantly elevated, right? At night, it is very much elevated. So these kind of nocturnal mass hypertension, you would not pick up unless you do an ambulatory blood pressure, because office blood pressure is mildly elevated. How do we suspect? Like we said, there's a discordance between the recorded blood pressure and their target organ damage. So your resident shows you an ECG, which shows a left ventricular hypertrophy. By whatever way you measure it, okay, you should think that can it be a nocturnal undetected mass hypertension? And you do an ambulatory BP, you find them. Unless you treat it, the target organ damage is going to progress and not just stop. There is one of our patients, you see, purely nocturnal blood pressure, where the elevation is restricted at night, and unless you do an ambulatory blood pressure, you don't detect it, and you see the heart rate is flat. There's no, normally there is drop of heart rate at night. When a patient sleeps, there's no drop of heart rate. The second area where out of office BP works is pharmacotherapy, to decide on what kind of drug you are going to start your patients and what kind of drug your patient is going to respond most. To understand that, we have to go back to ambulatory blood pressure recording. There's an ambulatory blood pressure recording. We know that that is the nighttime period. Says from 22, if you see the x-axis, night 10 o'clock to morning 6 o'clock. So as you see, the top of each of this bar column is the systolic and the bottom is diastolic. You see, as the patient has gone to bed, the blood pressure on top slowly has come down. That's a normal phenomenon that we call as nocturnal dip. This dip should be about 10% of the daytime blood pressure. So as a person sleeps, his blood pressure systole drops. Right. Now we know that daytime, the blood pressure is driven by sympathetic, right? We are talking, we are working, we're anxious. As we do things, sympathetic is driving our blood pressure. For example, white coat hypertension. It's the excess sympathetic discharge that drives it up, right? But generally at night, it is the renin-angiotensin system that drives our blood pressure. So the standard teaching is a daytime hypertension is sympathetic mediated more, right? And a nocturnal hypertension, for example, if you see there's a lack of dipping or an altered dipping is driven by the renin-angiotensin system. And moreover, if you look at that early morning rise, you see that early morning rise there, that is driven by combinations of both sympathetic vasoconstriction and altered renin-angiotensin system. And we know that that early morning surge is something that causes all the cardiac and neurologic events, okay, strokes, myocardial infarctions. So that early morning rise need to be tackled. Now the point is today we know that very few patients respond only to one drug, right? Very few responds to only a sympathetic blocker or a calcium antagonist or renin-angiotensin inhibitor. So anyway, you need to combine drugs. And that is what brings us to the 2018 ESH Guideline, where they say, try to use combination one single pill for compliance, right? So you start with a combination of a RAS inhibitor plus either a CCB or a diuretic. So either a RAS inhibitor, ACE inhibitor, ARB, with either a CCB or a diuretic. And with that, if you see that your blood pressure is not controlled, you go to a single pill, triple drug combination, which means a RAS inhibitor, a CCB, and a diuretic, right? And today we know that the majority of our patients would end up taking a combination of 3 drugs in a single pill. Single pill ensures that the patient is compliant and all the 3 drugs go in so that the pathophysiology of his blood pressure rise, both nocturnal and daytime, is countered. And of course, resistant hypertension. Now, I will end with 3 important studies that we have done from India, which everyone should be aware. First is the India heart study. In India heart study, what was done was patients had their blood pressure recorded in the office, went home with an BP apparatus like I showed. They were taught how to do it. They did it at home for 1 week and came back for follow-up. So office visit 1 week of ambulatory blood pressure, and office visit 2. Now, of course, this was not an absolute homogeneous population, but what was found is a large database. So obviously, the bias for selection would have got diluted to some extent, whereby we saw that we had an average age of 42.6, and then male, female 62%, and then slightly BMI high of 26.4. But that is not the point. What came out as surprising thing is this: the heart rate of the average Indian hypertensive turned out to be faster, to a tune of about 81.7 beats per minute. Now, this has been shown by very many, the BEAT trial in India. We have shown in quite a few data sets that signal that Indian hypertensives tend to have a faster heart rate. Now, does it mean that the Indian hypertensive is driven more by sympathetic? Maybe because of our social challenges, because of our workforce challenges, because of our day-to-day stress? We don't really know. But what we did find is that in most studies, the average heart rate of the hypertensive in India is faster. And today we know that a fast heart rate adds up to the risk of hypertension, of target organ damage, as well as events. So if we have a blood pressure which is well controlled, but the heart rate is high, that almost event rate equivalents to those whose blood pressure is uncontrolled and the heart rate is normal. So blood pressure and heart rate needs to be addressed, but unfortunately we don't have a data to say that in this group, if you reduce heart rate artificially, you actually gain. That data is unavailable. One of the world's largest ever ambulatory data set comes now from India, where we have done this ambulatory blood pressure trial with 27,472 patient data. The important things that we found out in India was two things. One, white coat hypertension was about 12%. And masked hypertension, interestingly, was about 19.3%. So you see about 1/5 of our patients have masked hypertension. And I'm sure all of us, you, me, everyone down there, we are missing a large number of masked hypertension. So again, I repeat, if we see a discordance between the measured blood pressure and the target organ damage, think of masked hypertension. This was a small review article that we wrote. We have been always talking about it. You see a lot of patients who come telling that they have dementia. They don't say they have dementia, right? But their spouse would say, doctor, my husband now forgets all the anniversary dates. He forgets where he put the mobile phone. He forgets about the car key, right? Mild dementia. You put them on a mini-mental scale and you would find that there is very early dementia. Now, a large number of these patients, obviously, if you do an MR, you might find a white matter hyperintensity, very small amount here and there. Do an ambulatory blood pressure, and you would find that there is a discordance, and they might have a nocturnal blood pressure or a masked hypertension. So if you miss masked hypertension in these group of early dementia patients, their dementia is going to progress, and by the time you detect that it is hypertension uncontrolled, the dementia would be in a state of unmanageable state. Finally, so where are we? Point number one, when we should advise out-of-office BP in India, when we have a discordance between office BP and target organ damage, we should advise for an out-of-office BP, either home BP or an ambulatory blood pressure. Point number two, we should advise home BP, that is out-of-office BP, when we are in a dilemma. Do this patient really need treatment? Does this patient really need drug treatment, right? Because I think that his blood pressure is uncontrolled, but he says he's fine. Home BP, ambulatory BP would give me the answer. Point number three, I'm trying to find out, will this treatment harm? Maybe at night, he has very severe reduction of blood pressure. Maybe once he's at home, he's feeling giddy, his blood pressure is going significantly down. So do I need to reduce his medication dose? Out-of-office blood pressure would give us that answer. We should not forget that most studies have shown 12% white coat hypertension and an incidence of 19% masked hypertension in India. And perhaps that very early dementia patient, you do a mini-mental scale, you find there's early dementia, you do a nocturnal blood pressure, it might be high. And if so, tackle that masked hypertension. Otherwise, his target organ damage, including dementia as well as ventricular hypertrophy, are likely to progress, and he might come back to you with an LV dysfunction. And of course, in today's world, what we are talking about is telemedicine, simply because we are talking about social distance. We don't want the patient to come back and physically see us, where there's a huge role of out-of-office BP. So I see the future where instead of everybody coming to the hospital office, standing in the queue, getting anxious and all that, we taught how to do a home BP. People who can afford to buy a home BP apparatus can actually do it at home and send us back their reports. So this is what we are actually thinking of. You know, the doctor actually coming out of the digital screen, and instead of the coronavirus testing, looking at his blood pressure. Thank you for your time, and with that, I hand over the screen to
Thank you, Tiny. A little overshot on time, but let me welcome Dr. Uday Jadhav back again, and he's going to tell us about central aortic blood pressure monitoring or organ-specific blood pressures. Uday, back to you again.
Yeah, thank you, Sandeep. Thank you very much. Thank you, Tiny. It was nice listening to your, concepts which you explained on ambulatory blood pressure and some of the things on masked hypertension. I will save some time so that we will eventually be at the same time clock. Okay. So what is the importance of measuring blood pressure in terms of the central aortic blood pressure? This is often, discussed these days. That is central aortic blood pressure important Should we start measuring it in all patients? I'm not sure you should start doing it in all patients, but it does add a value of information to the pathophysiology of hypertension and how we treat it. So we know the three main vital organs damage that occur: heart failure, stroke, and kidney failure. And I think what is missed, as I always feel is very important, the step after Dr. Tiny's talk on left ventricular hypertrophy is also atrial fibrillation. And this week's European Heart Journal has a very good study which talks about the trajectory of hypertension, longitudinal trajectory of the link of hypertension with atrial fibrillation and how things change. So I think European Heart Journal has truly come up with an excellent, complete, almost dedicated journal to hypertension this particular week. So when you talk about central and the peripheral arteries, the basic difference we need to understand is when you look at the ascending aorta and the proximal carotids, you are looking more at the elastic fibers.
Just a second, sir. We are not able to see your screen, sir.
Not able to see your screen.
Yeah.
You're not able to see my screen?
Yes. Not able to see.
Okay, hold on.
Yeah, now we can see.
Okay, that's interesting. Okay. I hope
Yes,
my comments.
now we can see it, sir.
Okay, my comments were heard, right?
Yes.
Okay, so fair enough.
Yes,
so we
sir.
just start, we continue where we are. There's absolutely nothing, different I talk. So if you look at the muscular arteries versus the elastic arteries, I mean, the proximal aorta and the carotids are going to look at the endothelium and the internal elastic layers, unlike the peripheral arteries. So as you go away, go to the brachial arteries, you have more smooth muscles and more muscular arteries, like the brachials, like the radials, and they decide on how the wave gets transmitted back. So here is the amplification of the wave. As the LV contracts and it gets into the conduit arteries, so this is not like a rigid pipe, right? These arteries are going to behave different at different points of time. And what you see initially is the ascending wave as the LV output goes into the aorta. That's the first proximal wave. And then as it goes into the peripheral circulation, you will have a reflected wave. So as the circulation goes into the multiple arteries, there are segments of waves that come back. They accumulate total, and you have one wave that comes back, and you can see that getting at the later part. So as you go from ascending aorta to the femoral artery, the one which is often used for central aortic pressure, the curves are different. The curves become more steeper with a later and smaller reflected wave. Blood pressure will remain mostly unchanged between the sides. However, the pulse pressure will be completely different at three sides. Why is this important? Because if you ask me what is the single most parameter in the central aortic pressure that on a clinical basis, I'm talking of clinical basis, can predict events, whether it's stroke mainly and cardiovascular events, it's the central aortic pulse pressure, right? So the pulse pressure is extremely important in terms of what it will decide. Here is typically the wave which is seen on a CABP monitoring. So you see the first is the incident wave, which is the flow out of the LV into the aorta. And then there is a reflected wave. This reflected wave, now what you need to look at is the augmented pressure, right? Augmented pressure is the notch of the incident wave and the reflected wave. So the difference between two is the augmented pressure. And and the augmented index is the augmented pressure divided by the pulse pressure. Pulse pressure, as we know, is the difference between SBP and diastolic SBP. Augmented index actually decides the level of arterial wall injury. So we need to keep AI into consideration in terms of when you do CABP measurements and clinical trials on the CABP, right? Whenever the reflected wave gets transmitted and hits in systole, there is a systolic augmentation of the pulse pressure. So the AP goes up, the augmentation index goes up. This will change between the ages also. So not that every age has got the same augmentation index. This is affected by aging. So this is the correlation between the aging and the central arterial stiffness. It depends upon how the arterial properties, manifest into the aorta, because that decides everything. That decides the vascular afterload. As I mentioned in my last talk, if a few people of you had attended, that it looks like LVH is also an independent phenomenon out of the blood pressure, and it's aortic stiffness that actually contributes to it independent of the blood pressure. So the aortic stiffness is extremely important. It also contributes to what is the coronary perfusion, the determination of subendocardial ischemia. There has been a trial of 10,000 volunteers that tries and show that there is a 70% or more overlap in the aortic systolic pressure. And you can see the graph very nicely. You can see the graph very nicely at these levels of brachial systolic blood pressure and aortic systolic blood pressure in the mid. All right, so how do we measure it? There are various measurements. You can do it by cath, of course, that's the gold standard, but you don't have to do it in clinical practice. Ablation tonometry is commonly done. My personal experience has been with ablation tonometry and the cuff-based oscillometer at the brachial artery. So you can measure the carotid femoral pulse wave indices also. Sphygmocor is very simple and straightforward, but expensive in this country. So you just can't go on doing a CABP in everyone that commonly. So this is a radial tonometry where you use sphygmocor, brachial cuff, PVP. There are multiple devices. Besides sphygmocor, BPRO is the other one, which is very standard. So these are the common ones which are used. Now we have BPRO devices also, which can measure your ambulatory blood pressure here at the wrist with a watch. So a watch device, which measures the ambulatory blood pressure monitoring, which also measures a central arterial blood pressure. Now, it's not that it measures central arterial blood pressure all 24 hours. But what it does is it samples and gives you an average of the CABP. So a dedicated 24 hours CABP devices are a little different, and they are also there. So this is the further trend in that. The CABP and the central systolic blood pressure are going to differ, right? So here is the range given from the young to the elderly between 100 to 122, depends on the age. If you look at elderly patients or elderly people above the age of 65 years, it's going to be somewhere between 115 to 122. And the central blood pressure threshold should be less than 130 by 90. Is it a risk marker? There have been studies which say that it's correlated with left ventricular hypertrophy, right? You can see all those studies. This is the strong heart study done in about 3,500 American Indians. The point is, as we discuss this ahead, that do you have a guideline or a therapeutic strategy saying that if you reduce the central aortic blood pressure, and that will happen with certain class of drugs, will it change the outcomes purely on basis of treating the CABP? I do not think we have studies of those which have been either addressed to it as a priori criteria, and we don't have an event reduction. And that's going to be difficult unless studies enroll this in all patients, where you do ABP, HBP, ambulatory blood pressure monitoring, and a central aortic pressure monitoring. Then it would be more worthwhile, and I don't think that's going to be difficult, really speaking. So aortic pulse pressure, as I said, correlates the best with the extent of coronary artery disease between the blood pressure parameters. Besides, of course, the established one like hypercholesteremia, and also correlates with the extent of coronary artery stenosis. The change in the left ventricular mass is linked to the central blood pressure and not to the brachial blood pressure. Now, mind you, this is a reasonably good study, but I'm again saying these are small sample sizes. This is not huge sample sizes that you can go on recommending this in clinical therapy. So I will stick to what Dr. Tiny Nair said, that you still need to be aggressive in the way you control the blood pressure with the best possible drugs available in clinical practice, rather than only using CABP to address this whole affair. Strong predictor of cardiovascular events than brachial blood pressure. The carotid pulse pressure is a strong independent predictor for all-cause mortality. So now you look at this study. It's a nice study. It looks at patients with end-stage renal disease. And our nephrology colleagues are very fond of this particular slide because they do a lot of central pulse pressure studies also. And this shows what is the probability of the survival. If the carotid pulse pressure is high and the augmented index, the A index is high, the augmentation pressure index is high, then in the third tertile, you can see that the survival practically is nothing in terms of what you would get over a period of 7 to 10 years. Aortic pulse pressure also predicts mortality. Now you can look at pulse pressure per 10 millimeter increase or diastolic blood pressure well controlled in clinical practice at 10 millimeter increase. I mean, the hazard ratio is highest with pulse pressure as compared to most of the other BP parameters. The clinical sort of diseases are always higher up there when you compare it. Carotid blood pressure is also an independent predictor of CV. So these are all telling you the same story over the last 6 or 7 slides, and I'm going to skip them because we need to now look at what is important. One was the cognitive function. So here is the mild cognitive impairment data. Carotid pulse, the central pulse pressure, as would be expected, is associated with mild cognitive impairment. You see, systolic blood pressure rise also has a significant link, in clinical practice with mild cognitive impairment. And if you go back to the HIVET study also told you that in the very elderly, it's important not to say that in the relatively fit patient, these blood pressures are acceptable. No, we need to get their BP down by a wise guideline to somewhere around 140 by 90 at least, if not 130 by 80 in elderly, so that you can achieve a better protection, not just against stroke, but against cognitive impairment. Central pulse pressure certainly has to play a role because that's what is going to decide the carotid circulation and the cerebral flow. Do we have clinical outcome data? Few data are there. Smaller studies, this is patient who is undergoing an angiogram and you look at the patient suspicious of CAD. Here again, there is a strong link between pulse velocity and the CAD. And these are the event reduction. These are very busy slides. We don't have to go through all this. In the Danish population also, it's been known to change the CV outcome. Let's come to what is clinical now in the last 5 minutes of our talk. That do we have drugs? Yes. Which are the drugs which can change the central aortic pressure? So I think the best evidence came from CAFE study, which looked at perindopril with amlodipine, and that is the gold standard. I think that was the biggest study in terms of event reduction. So ACE inhibitors are there. ARBs are also there, as we'll see in the next slides, and but not all of them. So the studies are very, they're unequivocal. At times you can find them just about there. There are times when they haven't reduced it as well. Beta blockers, certainly bad. In fact, it's been said that in the elderly patient with a high central aortic pressure, so this was a study I remember was by Professor Bera, published about 3-4 years back, and he looked at the central aortic pulse pressure on cath, on cardiac cath, the central pressure, and they showed that with beta blockers it's pretty less, and unless a ACE inhibitor or a calcium channel blocker is added, the central blood pressure doesn't settle down. So beta blockers for surely in elderly patients are not going to work unless there is a compelling indication. CCBs may probably reduce it. Diuretics, no change. Nitrates have that property by themselves, so they are going to reduce it. There was a study called Reason, which came, if I remember, before CAFE, and that was perindopril indapamide versus atenolol. And as you can see, at 6 months and at 12 months from baseline, there was a reduction in the central aortic pressure in the Reason study, followed next by the CAFE study, which showed that it worked. I just mentioned about CAFE. It's the upper one and the lower graph. The upper graphs, you are looking at the peripheral blood pressures, and then you are looking at the central blood pressure in the lower graph. What does it tell you? That when you use these drugs, atenolol plus thiazide, diuretic beta blockers versus perindopril amlodipine, the blood pressure change is also there, but it's small. But the central aortic pressure change is huge, and that led to a hypothesis, a theory, that the event reduction probably are more correlated with this rather than with a beta blocker and a thiazide diuretic therapy. In obese patient with hypertension, there has been a study of 6 months, and that shows that perindopril reduce the central aortic systolic blood pressure by a tune of 30 percentile as compared with the others. As you can see, telmisartan had 24%. There has been a study on olmesartan with amlodipine also as a combination, which also works. So maybe the new ARBs had some effect on the CABPs, but the classical studies have all come with ACE inhibitor and perindopril. Before I complete, and these slides are there as a summary slide, I also want to quote one more important thing from the European Heart Journal this week. And this has been going on for a while, that there are a lot of young patients in our country who get hypertension. Why is it that 30 years old patients get a hypertension besides a genetically predisposed aspect from the parents? The Mount Sinai School in New York looked at close to 42 lakhs of singleton live births, and they looked at the age group of 30 to 45 years and found that prematurity during pregnancy, if they are born before 32 weeks and if they are born before 27 weeks, make a great impact on future development of hypertension. Not that this was an unknown factor before, we already knew about it, but this youth study has for the first time shown what is the importance of prematurity in birth in the neonatal phase and the development for future hypertension in young adulthood, where you would not expect it to happen unless there is an established secondary cause, or there is a very strong genetic predisposition, which at times we do not find in clinical practice. In summary, central pressure predicts risk, predicts CVD, CKD, leads to impairment of the cognitive function. It's important to measure it in clinical practice at times when blood pressure therapy can make a difference. The best evidence available as of now is still with ACE inhibitors, with the classical study of perindopril with amlodipine. And whether we can use such a data, translate into clinical practice and say that this is what we should do for measurement of blood pressure in routine practice, that probably is a little too much to say at this point of time. Thank you, Tiny, and thank you, Dr. Sandeep. And at this point, I complete my lecture, and I stop the slides and we go ahead with the discussion, which you will take forward, Dr. Sandeep.
Yeah. Thank you very much. And you'll all agree we've had a wonderful, set of talks, and actually fantastic issues have come up. Uday, you started with the way we measure the office blood pressure. I think that you really covered that area very well. And for the benefit of physicians, there are a lot of mistakes that we make in routine practice, right from the patient supporting with the back unsupported, many a times in our government hospitals, particularly, the patient sits on a stool rather than sitting with a in a chair with a backrest. So the back is unsupported, and the legs are many times crossed. Those are very common problems. Then you also talked about the cuff size. I vividly remember one of my aunts. She was quite obese, and the upper arm was particularly obese, and the anesthesia people rejected her because they measured the blood pressure using the standard cuff. So I said, you measure the same blood pressure in her forearm, which is like more like matching with the cuff size, and the blood pressure was normal. So all of these things were, really stressed upon. They were very interesting, and you also talked about the number of readings to be taken. I remember last year there was a statement. Uh, there was a statement published by the American Society of Hypertension, and that had said that that had clearly said that the oscillometric method of blood pressure measurement is perhaps the best way to measure blood pressure in the routine practice. Uh, the other thing is that also said that in close to about 27 to 28% of the people, the first reading is generally high. And as you rightly said, and actually Tiny showed that that device which takes 3 readings. And I, in my practice, in my office, I also carry that same device, which I use for my patients routinely. So using 3 readings, using an oscillometric device is perhaps the best way to go about doing office blood pressure measurements. As I see, as of the moment, there are no questions. So perhaps we'll go ahead and carry on the discussion. So, Tiny, in your opinion, if you have to choose between ambulatory blood pressure and home blood pressure as the mode of the preferred mode of out of office blood pressure measurement, which one would you choose? Because both have their own advantages. Home blood pressure monitoring is over a longer period of time. It has its own advantages, but it doesn't give you the nighttime blood pressure. The ambulatory blood pressure monitoring will have its own problems. You have to go to a hospital again, and it costs a bit. And so which one do you think should be? And of course, both of them are not equally predictive of the future events. So which one do you think? I'll ask you, Tiny, first, and then we'll come back to the.
I think.
So what do you think? Which one of the methods?
See, there is no one-word answer for that. For example, our experience with ambulatory BP is so great. We had been using it for the last maybe more than 5 years now. So we have a lot of experience in ambulatory BP, and comparatively, the home BP concept has come new, especially with the new apparatus that you use. But I also use it in my OPD for patients who we see that the initial blood pressure is high. We put them into one of the corner cubicles, ask them to relax, and put this blood pressure apparatus, which records 3 times, and we get an average. So that is it. The advantage of an home blood pressure is that it is far more cheaper. We are using the same instrument. Only thing is that the patient needs to be a little more intelligent to know how to use it, how to put the blood pressure cuff correctly, and how to take the correct position and what time to take, and record it and bring it back to us. But it is cheaper, and it is one of the most accurate validated data that we have today on deciding whether the person has blood pressure, how high it is, and how should we escalate our drug therapy. But one thing that we don't get is the entire night's blood pressure. The advantage of ABP is that we get the entire night blood pressure. So I think it is still an area where we are learning, and we would choose depending on what kind of patients we think we are seeing. Still today, when we see an patient with an white coat hypertension, we still give him an ambulatory blood pressure, because the advantage is the ambulatory blood pressure will also tell that during periods of stress at his home or his office, how the blood pressure is reacting. We would also very clearly know about the masked hypertension and nocturnal hypertension entire night. We would also know about the early morning rise of blood pressure. So these three things are certain things which is better with ambulatory blood pressure compared to a home blood pressure. But home blood pressure is cheaper, more economical, and home blood pressure gives us a very accurate one single data, one number. If it is like more 35, 85, I know that the patient has hypertension and he needs more aggressive treatment. I think we should see what exactly we are looking forward from our patient and the subset modality.
Uday, I have two questions for you. First, I'd like your comments on home versus ambulatory blood pressure, although your topics were different, but you have a lot of work in hypertension, so I'd like your opinion on that. And the second one is, most of us have already, it is legally binding that you do not use the mercury-based blood pressure devices. So, in fact, we've given it in writing that we do not use the mercury-based devices, although you will find one with me in my office, which is like 15 years old. So, in your in the review currently, what percentage of people are, device, how many are using a mercury-based device, and how many are using these oscillometric devices in our country? Do you have any data on that?
So, for the home blood pressure monitoring, here is what I would suggest in clinical practice, that it will be better if you ask the patient to get the device to your consultation rooms in the office, and your assistant staff can check that device, see what is the variability between the blood pressure that is measured by your device, because we all measure automated office blood pressure devices, so that we have a sense of confidence, both as care providers and for the patients, that the blood pressure readings that is going to measure at home are going to be accurate. And we insist that the reading should be over a period of 1 week, leaving aside the first day, where it's done within 1 hour of his waking up and within just pre-dinner before he takes his food in the evening hours, and then average it. So we need 12 readings and not just 1 or 2 readings, and we tell the patient to play it slow and not revert back with every reading. It's important to do that. And when we check it with our own equipments, you need to have a 5 millimeters variation acceptable, not more than that. Otherwise, we need to be sure that these devices, either our own devices or the patient's devices, are in order. So that's one thing. Second aspect of home blood pressure monitoring that has come up very nicely now are the new set of instruments, like Omron has looked into it after Professor Carrio's research in Japan, that the home blood pressure monitor can be automatically triggered to measure it 2 hours, 3 hours, and 4 hours after going to sleep, or at decided hour, let's say 2 in the early morning, 3 in the early morning, 4 in the early morning. The point is, it almost takes care of some of the aspects that ambulatory blood pressure monitoring does. For example, monitoring for the nocturnal dip, or giving you a reasonably better idea that in the patient's home environment, what is the nocturnal blood pressure. So that's one comment. Second, about the ambulatory blood pressure monitoring, mercury sphygmomanometer, it's there in all consulting rooms. I use it for one thing. There are two aspects. One is that the patient feels very happy that the doctor also takes the blood pressure, not just that the staff does, because in my office, we have the automated office blood pressure, average 3 readings, but it is supervised. I'm not doing the unsupervised one as on now. It's supervised by a staff. And then I check the mercury manometer just to make the patients feel a little better and assured that just a human touch, nothing else. The mercury manometer inevitably records, in my experience, on average, about 10 millimeters higher blood pressure than what the staff records outside on the automated office BP. And I have plenty of gadgets, and we check the variability between the gadgets also just to be sure, because it's not that every time the automated office blood pressure absolutely perfect. So we need to be sure from time to time that we just don't take it for granted and go on recording the wrong readings. So sphygmomanometer, that way is still used, but it's not to be promoted. So we tell, as you mentioned, and you correctly mentioned, I'm sure Tiny has a comment to add. We tell clinicians to utilize it more and more, but well, like everything in history, it has been there and it has served a purpose. I don't see what was wrong in it being there all these years around. Tiny, your comment, and Sandeep, you can take.
Yeah, Tiny, before you answer, please also answer between the two, between the home blood pressure monitoring and the ambulatory blood pressure monitoring, which has a better predictive value in terms of events like stroke or myocardial infarction, which has a better predictive value, or they're both equal?
The better predictive value is obviously by the ambulatory blood pressure, no doubt about that. Because once we get an average nocturnal blood pressure, we know studies after studies show that average nocturnal blood pressure is the best predictor of a future, even be it stroke or myocardial infarction. We are not talking about the early morning rise, right? So that can be right now only by an ambulatory blood pressure. If we are talking about an event, there is no question it is ambulatory blood pressure. Right, that is question. The second thing about, I fully agree with Dr. Uday as to the sphygmomanometer, but the point is in NABH accredited hospitals, like the one that we all are, right? Any accreditation, first thing they will say that they will throw mercury. Mercury is an environmental toxin. So they will not let you even keep one mercury manometer to teach students. So we have to throw it out, because if they find one, they are going to put it as a non-conformity, right? So you have to end up with an either a manual aneroid or an oscillatory. Obviously, oscillatory and manual aneroid are different because we are looking at different things. One is we are looking at the Corotko sound. The other one is looking at the oscillometric rise and fall and taking a mean of that. Taking a diamond with minus 30 and plus 70 and minus 60, right? So it all depends on the algorithm that is fitting. And we know studies have shown that aneroid, the physical measurement will be different from oscillometer, right? That is different. But I think mercury is out. We can't keep a mercury because of technical reasons. Government of India would have also recommended that you can't keep a mercury manometer.
So we have some questions come in. So just to interrupt, we have quite some questions. So I'll go to the first one, which is Dr. Vasa asking sleep disturbance and ambulatory BP monitoring, your comments.
Disturbance and ambulatory BP monitoring?
Correlation and reliability, your comments.
Correlation and reliability of ambulatory blood pressure monitoring. Tiny.
And sleep disturbance.
Yeah, probably.
Tiny, you did stress upon that. You did stress upon that. Not and it is not a nocturnal blood pressure monitoring. It is a disturbed sleep monitoring. So there's Dr. Vasta. He wants to know how important is that. You know, you get disturbance of sleep, and how important is the reliability of ambulatory blood pressure monitoring?
It is one of those problems of ambulatory blood pressure where the sleep is disturbed, and we know that once the sleep is disturbed, obviously the blood pressure will go up, right? So we are trying to get into newer devices, like Dr. Uday said. One of this is a tonometric watch-like device that does not compress or relax. Okay, it just keeps on your radial artery, and by applanation tonometry, it continuously records the wave, so that it gives you ambulatory blood pressure continuously without any inflation or deflation. Now that we had about, we've given one of the devices for test. We don't know, but we have to test it with gold standard. Once that shows that it is truly matching with our standard ambulatory blood pressure, I think that would be the best. It doesn't disturb your sleep and it goes on recording. The other part of the whole story would be that do not forget that obstructive sleep apnea. might be connected with a nocturnal blood pressure. And there your sleep disturbance along with the nocturnal blood pressure rise comes in.
Yeah. Uday, if I may ask you, we know that there are a set of drugs which are going to reduce the central aortic blood pressure. In fact, of the first 3 drugs that we use currently, the world bodies advise that the first or the second drug would be an ASAB or a CCB, and you combine these two or add a diuretic. I mean, the first 3 drugs are RAS inhibitors, calcium channel blockers, and diuretics. We know that for sure. And we also know that both the ASAB and the CCBs are the drugs which are going to lower the central aortic pressure.
Okay, so my combinations would be just enforcing the views which you just expressed, is that you use a RAS inhibitor because it's known to reduce the central aortic blood pressure, ACE inhibitor in these clinical studies. You combine it with calcium channel blocker for another very important reason. Calcium channel blockers are known to reduce the blood pressure variability, and that's considered a very important aspect of reducing CV events. And there has been, after the recent Legend data which came up, there has been so much interest again generated in the use of thiazide-like diuretics, whether they're chlorthalidone or indapamide. I mean, the thiazide-like diuretics also have shown, in fact, the highest superiority in terms of reduction of events. So the Legend published in Lancet and the JAMA Cardiology has already told us these messages. I think, so these are the 3 group of drugs that would be very, very useful. Now, if you look at central aortic pressure, your concern would be more when patient age and have become elderly. So that's the point of time, I think, CCB, the RAS inhibitors, the CCB, and the thiazide-like group of diuretics as 3 class of drugs, one or in combination, dual or triple combinations, would make a great impact. I think the drugs that are not likely to work are the beta blockers, and the drugs which have a concern would be the alpha blockers. Tiny?
One comment to that. See, we have conscious. I understand that we are looking into the triple therapy combination of CCB and RAS inhibitor and diuretic, right? But let's say we have so much of data now telling that the Indian population's heart rate is high, number 1. And number 2 is that all the beta blocker trials that you have shown raising your central blood aortic pressure are all done with atenolol, right? We don't have the data with the newer selective beta blockers like bisoprolol and nebivolol, which we have discussed the other day also. So where would you put beta blockers in the algorithm of hypertensive? Because, okay, we have the standard 3, but next what? Because we have inherently a faster heart rate. What would be your comment on that? And after Dr. Sandeep also.
Okay, so I'm going to quickly comment on it. And so it looks like this will be, so I went on saying that the elderly is where the beta blockers may not be useful. The younger ones where the beta blocker may be useful. Actually, you know, Tiny, so I am already onto the study, so I cannot reveal further data. You will also be a part of this. You see, we are using heart rate as an indicator of sympathetic overactivity. And we are saying, if you reduce heart rate, you are going to reduce sympathetic overactivity, and that heart rate necessarily is a marker of sympathetic overactivity in hypertensive subjects. And therefore, if you target heart rate based on those fundamentals, then it will make a change in the event rate. Now, there are 2 important questions here. One, that heart rate elevation may not necessarily be evidence of heightened sympathetic activity. There are 2 very good papers on this which are not supporting it. So that's an interesting thing which we'll have to follow up. Secondly, whether in a subject of hypertension, heart rate should be one of the markers to decide the blood pressure lowering therapy, and that will change the event rate, is absolutely a, what do we say, is it a novel concept, or it is a area which has been untreaded and we will only find answers for ourselves. Now, I agree with you that the some of those beta blockers with those unique properties like vasodilating properties would have a role to play. And it's time that we take it forward and see whether we are able to find those results. So this is hypothesis generating. There is a validity to it. It's never been looked at. The reason we are doing this whole survey and study is saying that just because the guidelines tell you not to use it, but the guidelines never even looked at it, right? They have never even, as you said, looked at the whole fundamentals of it. But are we only harping on sympathetic overactive and heart rate as interconnected, complete connections? That I do not know. Dr. Sandeep and Tiny, then back.
Yeah, actually, I think I'll make the last comment before we go on to the take-home messages for this session. We are already, the time is already 5:20. My thought on this is that.
So we have a couple of questions. Can you just
Yeah. Okay. Please tell me the question.
Couple of questions come in. Yeah. So Dr. Jugal has digital aneroid and mercury.
The audio is not clear, Nishita.
Digital aneroid and mercury sigmomanometer, which one to prefer? Which digital machines are good? Any FDA approved?
Which digital machines are good? Uday, that's a question for you, Uday. Which digital measurement machines are good?
There is a list. I mean, I can forward it to the Serdia people and they can forward it to the question, because there is a list, of the validated, the approved one. So this goes by, there is a British Instrumentation Association, which checks the validity and certifies them as to be used for HBP and ABP use.
Actually, I can tell you that there is American Association of Medical Instrumentation, AAMI, and then there is British Hypertension accrediting bodies. Over a period of time, two more have come in. One is the German, and the other is the WHO accreditation. So at the present time, there are 4 accrediting bodies in the world. And if you have a device which is accredited by any of these bodies, that should be good. But yes, Uday has a list. He'll forward it to the Serdia people, and then it can be forwarded to the person concerned. And Nishita, any more questions?
Yes, sir. So should you advise calibration of home BP machines? If yes, how often?
I think that question was touched upon by Uday. He told that you should get the home blood pressure measuring machine to ask a patient to get it to your office, and your assistant calibrates it on the machine that you are using, and perhaps that's the way to go forward.
Right. And just last one, ABPM, 24-hour, 48-hour, 72-hour. Which one is better?
I think, I think you are confusing probably ABPM with an Holter monitor.
Holter monitor, yes.
It's available right now only for 24 hours. You have Holter monitors which extend to 7 days and 10 days. But right now, maybe a time will come where you would have a non-pressurized watch-like device that would record your ambulatory BP. Even you keep for 3 days, doesn't matter. But right now, it will be a torture if you put the patient on a 3-day ambulatory blood pressure.
Yes.
Right.
Okay. So.
Yes.
Any more questions, Nishita?
No, sir. Nothing from my end. I would just like to say that we have developed on ABPM, HBPM, and Office BP. We will share with everybody soon. A patient education video which the doctors can share with their patients.
Sure. Okay, then time for take-home messages. First, Dr. Uday, and then Dr. Tiny, and then I'll make the final comment. Uday, what would be your take-home messages for the people watching the show?
So, to make it a little shorter and crisper, we need to use the the home blood pressure monitoring as one of the criteria to define hypertension, and it should be a valid instrument. If we are checking the blood pressure inside our own consultations, we need to move forward from sphygmomanometers to automated office blood pressure, which averages 3 readings all basic precautions, like patient should be adequately rested without smoking or a coffee or alcohol, should void his bladder or an empty bladder, sit not cross-legged, sit with his feet firmly planted on the ground in a relaxed fashion, blood pressure taken with the sleeve properly uprolled with an adequate cuff measurement, and in the patient sitting with the arm at the level. That's the most important thing in terms of how we can arrive at the blood pressure measurement. Home blood pressure monitoring should be the step one before we progress for ambulatory blood pressure monitoring. And when it comes to central aortic blood pressure monitoring, it's going beyond the research tool now, like ambulatory blood pressure monitoring, helping us in clinical practice in terms of selecting drugs. It looks like in the elderly patient where CABP gets more impaired, the RAS inhibitors, ACE inhibitors, the calcium channel blockers have a certain role to play. Thiazide-like diuretics are emerging for reduction of CV events, and that beta blockers may fall in line in young hypertensives, but only time will tell as more clinicians and researchers will put in their own efforts in this country. Thank you, Sandeep.
Tiny, your comments, your take-home messages before.
One is that the first question is out of office ambulatory blood pressure, home blood pressure for everyone. No, because we have a huge number of hypertensives out there. You have to select which of your patients needs actually an ambulatory or a home blood pressure in India. So how do you select? Number one is discordance. If you find there's a discordance between your measured blood pressure and target organ damage, either nephropathy, urine albumin, microalbumin, left ventricular hypertrophy, retinopathy, go for an ambulatory blood pressure, number one. Second, if despite treatment, your patient's blood pressure is uncontrolled, and you want to make sure what extra therapy you want to add, ambulatory blood pressure. Number three, if you think that you want to reduce your patient's medication, patient is fine, and you want to reduce medications, is it okay to reduce medications? Ambulatory BP is good. Apart from this, probably ambulatory BP should not be used in India because a large amount of cost factor comes in, availability comes in. Don't think that it's for everybody. And do remember that obstructive sleep apnea can alter or create a masked hypertension at night.
Thank you. And my take-home / concluding words, I would like to say we've had a fantastic session. I have learned that we need to measure the blood pressure in our offices using oscillometric devices in a proper manner. Use an accredited device. Try and understand that not everybody will need an out-of-office blood pressure monitoring. There are specific subsets. One being discordance in the between the blood pressure measurements or between the target organ damage and the level of blood pressure that is measured. It also has importance in terms of therapy. And finally, above all, use your wisdom, use your judgment to manage your patients the best. With that, I think we are reaching close to the end of this session. And I'd like to thank you, Dr. Uday Jadhav from Mumbai and Dr. Tiny Nair from Trivandrum. This is Sandeep Bansal from Delhi. Closing this. Over to you, Nishita, before we close the...
Thank you so much, everybody. I would like to thank even the people attending the session for all the questions which have come in. We have answered very few. Thank you so much for your active participation. And thank you to all the three speakers also, Dr. Uday Jadhav sir, Dr. Sandeep Bansal sir, and Dr. Tiny Nair sir. Thank you.
Thank you.